Thank you very much, Chairman, and I would like to thank ECR for this kind invitation to come and speak to you, and thank you all very much for coming along. Dr. Cowan has spoken about the contribution that imaging has made to the diagnosis of stones, and this is one of the great success stories of uroradiology. The second one was probably our ability to identify renal masses, but we now have a near-perfect diagnostic tool, which is a CT-KUB. Now, of course, with these kind of things, even when you have a near-perfect diagnostic tools, then one has to look at what exactly the information we are getting on, how does it actually impact on management, treatment, and final patient outcome. And the talk of this, the title I was given was, what is the contribution we can make once we made the diagnosis to planning urinary stone treatment, not just for the interventional radiologists like myself, but also for the urologists. Well, there are some facts which one can talk about. And one thing is that successful stone treatment depends on a few items. One is the size of the stone. Secondly, the stone density. Thirdly, location. And lastly, the collecting system anatomy. And we'll go through these things. Now, what's important about all these things is that although we have made enormous gains in our diagnostic ability with stones, our ability to clear stones, in other words, sterilize a patient of all stone disease, is not perfect. This is a graph I took from the AUA guidelines, which are broadly similar to the EAU guidelines that Nigel told you about. But stone clearance, we're still stuck after PCNs at approximately 80%. There have been many technical advances, but we are still stuck at 80%. So we should now concentrate on how we can improve stone management. It has come with big problems as well, which I shall allude to. Now, let's talk about size. Well, the document, the EAU guidelines, has quite clear cutoffs. And in those patients who have got symptomatic stones, if their stone is less than 1.5 centimeters, they would be eligible for surveillance, extracorporeal lithotripsy, or flexible ureteroscopy to break the stone and remove it. Those with stones greater than 2 centimeters are by preference should be treated with PCNL. And the guidelines go through why this is justified. Regarding ureteric stones, the cutoff seems to be around 5 centimeters. Now, the problem is that the data in ureteric stone treatment are based on axial measurements on CT and coronal measurements on IVU. So how they relate to in modern practice is not clear, but still 5 millimeter cutoff for ureteric stones is useful. And as you can see, stone less than 5 millimeters, sorry, I said 5 centimeters, 5 millimeters is highly likely to pass, whereas that more than 5 millimeters is less likely to pass. So stone size does govern treatment choice. But then that also brings us to the question, how do you measure a stone? I think Nigel explained very clearly that just relying on one axial plane is not sufficient. One should look at the orthogonal plane. Trouble is, our CTs are, unless it's Nigel who makes orthogonal planes, are either coronal or axial, whereas ultrasound, by its nature, is always an orthogonal plane measurement. And abdominal X-ray, of course, is restricted to the coronal size. But what is, in my own practice, because of reproducibility, and the renal stones, I rely on axial stones. And ureteric stones, I go for the coronal dimension. So that's on my own practice. But I realize that that may not be everyone's preference. Now, also, one has to optimize CT factors to measure your size accurately. It is known that if you use bone settings, thin slices, and magnified images, you can reduce your partial volume errors and those errors due to spatial resolution. And you can get quite a high inter-reader variability as described in this paper. So one has to optimize your CT scans to measure those stones accurately. And you see in this example how two stones lying side by side on a soft tissue windows are clearly separate stones. And of course, treatment will be based on the largest size of a given stone. So it's important to optimize your CT fractals. Now, you might say to me, well, wouldn't that mean that stone volume is the most useful governing factor regarding whether a stone should be treated? And that probably is true. Its trouble is we do not have sufficient data to make that. And that is an area that should certainly be studied further. But we are talking about stones of a significant size, more than 4 millimeters, more than 5 millimeters, wherever you set it, which also brings with us the problem of when is a stone not significant. CT-KUB, I said, was one of the diagnostic revolutions in uroradiology. It improved our diagnostic abilities greatly. We were able to measure stones and so on. But equally, we are now picking up lots of little plaques and little fragments. And this brings me back to an original paper which was from way back, and it's what's called Alexander Randall's plaques. And Alexander Randall was a urologist in New York who had this theory that stones begin as little calcium deposits within the collecting ducts and then progress onto stones. Now, this is a theory that was not further investigated after he first proposed it because we were not able to investigate it. But it's come back again because, firstly, we are identifying these little things here, and secondly, are they clinically relevant? So it's presented CT-KUB with all its advantages has actually raised a monster for us, what to say about these kind of stones. My own view is that stones or any kind of calcification less than 2 millimeters I call a plaque. Now that is just a sensible, or rather my own personal view on this, and sadly at the moment we do not have any reliable way of differentiating Randall's plaques, or just plaques as you might call them, and true calyceal calculi. It still is a problem. But I take the view that anything less than, and this is something that I've discussed with my urologists and I've come to an agreement with them. Unfortunately, we do not know what is the long-term outcome of Randall's plaques as yet, but some initial data suggests that they may predict chronic stone formers. In other words, it might be a clinically relevant information to pass on. Size governs treatment, but so does the density and the composition, because both these factors govern what is the likelihood that a given stone will fragment, either easily during PCNL or using extracorporeal lithotripsy. The data are not very defined, very clear on this, and some people set a threshold of 800, whereas others put it at 1,000 Hounsfield units. Partly this reflects that actually stones have a variety of densities, and it's very difficult to get a very clear or precise reading of the Hounsfield density of a given stone. So the density of a given stone is also another piece of information that will influence management. A stone greater than 1,000 Hounsfield units would, in our practice, would preferentially go for PCNL, whatever the size. Certain compositions also make a stone less likely to fragment, and for some reason, cystine stones or oxalate monohydrate stones. Now, which is fine. We know that certain compositions do not fragment well, but at the moment, radiologically, we do not have a reliable way of investigating a stone composition. There was great promise with dual energy CT, and in this paper here, which is a rather large paper, 80% accuracy for predicting of uric acid stones. Unfortunately, the numbers were quite small. Nevertheless, beyond uric acid, the ability to predict stone composition is not so good. So there needs to be more work on that. Can we better predict stone composition? Location in the ureter is also a governing factor. And these, you can think of these in broad terms, 50, 60, 75. Nigel split the ureter into abdominal and pelvic. The urologists still stick to upper third, middle third, and lower third, but they're not arithmetical thirds. That merely relates to how they see changes in the configuration of the ureter as they go up. And one can use the sacrum as well. Whether you use abdominal and pelvic or whether you use thirds, you should just have an agreement with your urologist. In other words, transmission of accurate information, communication, which is a factor that I'll come on to. So stone size, composition, location in the ureter, and also the last factor is the collecting system anatomy. Now, certain stone locations, by their nature, are not easy, will not easily drain after years treatment. So, for example, this stone, in a dependent calyx, even if it fragments well, will not naturally drain. And it has been shown with some evidence, it's quite mixed evidence, that long infundibula, narrow infundibula, and acute angles are unfavorable anatomical findings. This was in the days of IVU. But in more modern terms, anatomical planning for stone surgery is becoming even more important. In a way, anatomical planning is becoming important in lots of things that we deal with as uroradiologists. I mean, the talks this morning were on prostate cancer, and our location of the primary or index focus is becoming an important bit of information to communicate to our surgeons and ourselves. Regarding stones, knowledge about how the collecting system, the ramifications of the collecting system around the stones will help plan navigation, as I'll show you, and also helps access planning. But that brings with us a communication problem. Sometimes we produce a vast amounts of information in our radiology investigations, and we've come to the stage where actually it's difficult to communicate all that information using just words. And you have to now move on to something else. And regarding stone planning, one of the things that is very useful for communicating information is 3D video loops of a CT pyelogram, such as this. These are things that I use for my own access planning. So, for example, in here, one can predict that to get to that stone and that little fragment, one could come in through this calyx, pick that out, and deal with all that. In other words, you could predict that one access would give you complete stone clearance. Whereas coming in, for example, here, that angle would be too acute, that's a bit narrow. Coming in here, well, you'd have difficulty picking that up, and you might have difficulty navigating around the corner. So anatomy is great. 3D anatomy is great, but you have to communicate it, and these kind of loops are very useful for it. But one has to optimize your study. This is not just a CT urogram. This is a CT pyelogram. And the important thing you are doing here, I think Nigel alluded to it in that you are giving saline as well as furosemide to make sure that you develop an even concentration, contrast concentration in the collecting system without any streak artifacts from the collecting ducts and the calyces. This is a protocol we use at the moment. And what this does, it gives you an even contrast concentration in the PC system of approximately 200 Hounsfield units. But more importantly, as most stones are 300 or 400 Hounsfield units or above, you get a gradient of 100 Hounsfield units, which allows you to see the stone as separate from the collecting system. And then I go on to create these video loops. And they were quite simple to create in that sense that you set the threshold at between 100 to 120, which cuts out the soft tissues and leaves the calyces and the stones. And then I just use the simple cut tool to remove extrarenal structures. And that allows me to create these kind of loops for planning. So again, 3 possible targets here. And here, I thought that we'd need 2 tracks, because to get round to this one couldn't come from here, and to get round to this pelvis, one couldn't come like that. So this required 2 tracks, and you could achieve complete stone clearance. And this is just a paper showing how that technique guarantees an even contrast concentration versus the stone, and you get a gradient which is sufficient for accurate stone reconstruction. And this is another example where, even though it's a complete staghorn calculus occupying every calyx, because one could identify a posterior-facing calyx, you could predict that you would be able to navigate around this entire system and get that stone out. So just a single track was. But you could also predict that sometimes it's not going to work. I don't know why it's not going to the next slide. Can you help me? Oh, there you go. This is the next slide. Here, this stone is in a very narrow-necked calyx, and it's in a very unfavorable angle. And however, whichever way you came in, there's no way you could get that stone out unless you went into it directly. So here, with a single track, you could take all those stones out and leave this one for later ESWL. So I hope I've shown you with those examples that anatomical planning does have a great value in the planning stone surgery. But just to recap, regarding planning of urinary stone therapy, there is a minimal data set that one should aspire for. Number 1, the number of stones one sees on your modality, the size of the stones, and I feel that renal or calyceal stone should be measured in maximal axial on CT-KUB, whereas ureteric, probably maximal coronal. The location, and one can use broad terms like upper calyx, interpolar calyx, or middle calyx, or lower calyx, renal pelvis, and regarding ureter, well, either abdominal or pelvic ureter, or upper, middle, and distal ureter. Calyceal anatomy. So I use broad information at the moment. It's located in a dependent calyx with acute infundibular angle or in a diverticulum. And I don't formally give the angles or sizes of infundibula as yet. And the renal appearance, whether there's hydronephrosis or cortical loss. So that's the kind of minimal data set regarding imaging in planning urinary stone therapy. And if you want the full thing, then, of course, the CT pyelogram gives you exquisite anatomical information. Thank you very much for your attention.